The morphology of a cell and tissue injury. All stresses and noxious influence exert their effect first at the molecular or biochemical level. Cellular function may be lost long before cell death occurs, and the morphological change of cell injury lag far behind birth. Reversible injury, also named degeneration. The two main morphological carnations of reversible cell injury are cellular swelling and fatty change. Cellular swelling is the result of filling of energy-dependent iron pumps in the plasma membranes, leading to an inability to maintain ionic and fluid homeostasis. It is the first manifestation of almost all forms of injury to cells. It's difficult to appreciate with the light microscope. It may be more apparent at the level of the whole organ. When it affects many cells in an organ, it causes some payload, increased turgor, and increase in weight of the organ. Microscopic examination may reveal small, clear vacuoles within the cytoplasm. This represents distended and pinched-off segments of the ER. This pattern of non-lethal injury is sometimes called hydropic change of vacuolar degeneration. Fatty change occurs in hypoxic injury and various forms of toxic or metabolic injury, and is manifested by the appearance of small or large lipid vacuoles in the cytoplasm. The appearance of small or large lipid vacuoles in the cytoplasm. Under some circumstances, cells may accumulate abnormal amounts of viral substance, which may be harmless or associated with varying degree of injury. The substance may be located in the cytoplasm within organelles, typically lysosome, or in the nucleus, and it may be synthesized by the affected cells or may be produced elsewhere. There are three main pathways of abnormal intracellular accumulation. A normal substance is produced at a normal or an increased rate, but the metabolic rate is inadequate to remove it. An example of this type of process is fatty change in the liver. Fatty change refers to any abnormal accumulation of triglyceride within parenchymal cells. It is most often seen in the liver, since this is the major organ involved in fatty metabolism, but it may also occur in heart, skeletal muscle, kidney, and other organs. A normal or an abnormal endogenous substance accumulates because of genetic or acquired defects in its folding, packaging, transport, or secretion. Mutation that cause defective folding and transport may lead to accumulation of proteins. An abnormal exogenous substance is deposited and accumulates because of the cell has neither the enzymatic mechanism to degrade the substance nor the ability to transport it to other sites. Accumulation of carbon or silica particles are examples of this type of alteration. Here, we will introduce two forms of intracellular accumulation, fatty change and pathological calcification. Hepatic steatosis may be caused by toxin, protein malnutrition, diabetic mellitus, obesity, and anorexia. Alcohol abuse and diabetes with obesity are the most common cause of fatty change in the liver in industrialized nations. Free fatty acids from adipose tissue or ingested food are normally transported into hepatocyte. Excessive accumulation of triglycerides may result from defects at any step from fatty acid entry to lipoprotein exit, thus accounting for the occurrence of fatty acid after diverse hepatic insults. Hepatotoxin, such as alcohol, alter mitochondria and SER function and thus inhibit fatty acid oxidation. Anoxia inhibit fatty acid oxidation, and starvation increase fatty acid mobilization from peripheral stones. Fatty change is reversible. In the severe form, fatty change may precede cell death and may be ordination in a serial liver disease called non-alcoholic steatohepatitis. In any site, fatty accumulation appears as clear vacuoles within parenchyma cells. Spatial staining techniques are required to distinguish fat from intracellular water or glycogen, which can also provide clear vasculars but have a different significance. To identify fat microscopically, tissue must be proceeded for sectioning without organic solvent, typically used in sample preparations. Usually, frozen sections are used. The fat is then identified by staining with sodium third and oil red O. This stain fat orange red. The vacuoles don't stand for either fat or glycogen. They are presumed to be composed mostly of water. Mild fatty change in the liver may not affect the gross appearance. With increasing accumulation, the organ enlarge and become progressively yellow, soft, and greasy. Early fatty change is seen by night microscope as small fat vacuoles in the cytoplasm around the nucleus. In later stage, the vacuoles coalesce to create clear spaces that displace the nucleus to the cell peripheral. Occasionally, contiguous cell rupture and the enclosed fatty globules unite to produce so-called fatty cysts. In the heart, lipid is found in the two patterns: prolonged modulate hypoxia, as in profound anemia result in focal intracellular fat deposits, creating gross apparent bands of yellow myocardium altering with bands of darker red-brown uninvolved heart. This is so-called tiger effect. The other pattern of fatty change is produced by more profound hypoxia or by some forms of toxic injury and showed more uniformly affected myocytes. Pathologic calcification. This is a common process in a wide variety of disease. It implies the abnormal deposition of calcium salts, together with smaller amount of iron, magnesium, and other minerals. Regardless of the site, calcium salt is grossly seen as fine white granules or clumps, often filled as gritty deposits. Sometimes a tuberculous lymphocyte is essentially converted to a radiopathic stem. Histologically, calcification appears as intracellular and or extracellular basophilic deposit. In time, heterotropic bone may be formed in the focus of the calcification. Dystrophic calcification is encountered in areas of necrosis of any type. It is virtually inevitable in the atheroma of advanced atherosclerosis associated with intimal injury in the aorta and the larger arterioles and characterized by accumulation of lipids. Dystrophic calcification of the aortic valves is an important cause of aortic stenosis in the elderly. Initiation extracellular site occurs in membrane-bound vesicles derived from degeneration cells. It is thought that calcium is initially concentrated in these vesicles by its affinity for membrane-bound phosphorylates. Inhibition of intracellular calcification occurs in the mitochondria of dead or dying cells that have lost their ability to regulate intracellular calcium. After initiation in isolation, propagations of crystal formation occurs, and phosphorylate in the extracellular space. the presence of mineral inhibitors, and the degree of the collagenization, which enhances the rate of the crystal growth. Metastatic calcification can occur in normal tissue whenever there is a hypocalcemia. The four major causes of hypocalcemia are increased secretion of parathyroid hormone due to, firstly, isoprimary parathyroid tumors or produce of parathyroid hormone-related protein by other malignant tissue. Secondly, destruction of bone due to the effect of accelerated turnover, such as Paget disease, immobilization, or tumor. Third, vitamin D-related disorders include vitamin D intoxication and sarcoidosis, in which macrophage active a vitamin D precursor, and last, renal failure, in which phosphorate retention leads to a secondary hypoparathyroidism. That's all for this section. Thank you.